Thank you. First, I'd like to thank the organizing committee for inviting so many women as presenters. And thank you for inviting me to talk about the current initial treatment of CLL for young patients in such a wonderful town. These are my disclosures. So I think that we can agree that at least in the pre-chemo-free era, FCR has been established as a standard of care for fit patients. We have the results of 2 German trials, FCR versus FC and FCR versus BR. And we also have the very long-term experience of the MD Anderson with FCR. So the first question is, who is FCR ineligible? I think that there is a consensus that patients with 17p and or TP53 mutation should not receive immunochemotherapy. These are the results of the CLL-8, but there are some other trials that have shown the same thing. But I think that it's also important to point out that the reality that is even in trials, most patients are tested for 17p and not yet tested for TP53 mutations. So I think that's something that we really need to work on. So for these ineligible patients, ibrutinib in frontline, is it the standard of care? There are abundant data in relapse refractory, but I was surprised that data in frontline are surprisingly scarce, and the data that we have are mostly subset of patients in trials for elderly patients. For example, the Illuminate shows a very great benefit for the patients who receive obinutuzumab. In the Alliance trial, ibrutinib and ibrutinib R is doing much better than BR. And there is that phase 2 trial where treatment-naive patients and relapse refractory TP53 altered patients were treated with ibrutinib, and you see here that the estimated 5-year PFS for the treatment-naive was 74.4% with a 5-year OS of 85%. So these data compare very favorably with immunochemo, whether in frontline or in relapse refractory patients. So what do we mean by FCR, and who is FCR eligible? Well, FCR, is it IV or oral? Is it 3 or 5 days? What's the median number of cycles? And what threshold for creatinine clearance are we using? Are we using fitness or age? Chronological age is not a reliable surrogate for physiological age or fitness. And if you look at these 2 guys there, they look really fit. So are they eligible? In France, they would be. In other countries, no, because they are over 65 years old. So can we adapt FCR to have less toxicity? Marotoxicity leads to infections, but the supportive care reduces the infection rate and severity. So I think it's important to think about the systematic use of growth factors through every cycle of therapy, prophylaxis for pneumocystis, IG substitution for patients with a previous serious infection, and vaccination prior to immunochemotherapy, in particular flu. Some options for reducing the marotoxicity have been considered as well. Reducing the number of courses to 4 cycles, that's what we have been tested in the French trial with a median age of inclusion at 70 years old, and the patients received 4 cycles, and 78% of the patients were able to receive the full abbreviated regimen with a median PFS which is 55 months, which is similar to other trials, no cross comparison, but with 6 courses and younger patients. Adapting the fludarabine dose hasn't been as successful. There is a great concern with second malignancies, and they are increasingly scrutinized as life expectancy in CLL is increasing. And we had that talk by Moritz Fürstenau in the YIM, and I think it's a very good data, and he was kind enough to give me the slide of that German registry on these second malignancies. And of course, there is an increase incidence in treated patients. But I think it's important to note that the increase in hematological second malignancy is not as high as has been suggested by previous studies. And also, I was interested to know that fludarabine-based chemoimmunotherapy in this registry seems to be associated with a low incidence as compared to other chemotherapy regimen with the same age, for example, for BR. So also there is an increased risk of AML, which is really more important in the more elderly patients. And I think we have to keep in mind that we don't have long-term data on incidence of second malignancy in chemo-free regimen. So who benefits the most from FCR? Well, obviously the IGHV mutated cases. We have the MD Anderson group that has reported 53.9% of patients with mutated IGHV. We are still in remission at 12 years. Versus less than 10% in the unmutated cases, and no relapse was seen among 42 patients beyond 10 years of follow-up. There is also a meta-analysis of CLL8 and CLL10 from the German group with quite a good follow-up, and the median PFS was not reached for the IGHV mutated patients. But in these cases, do novel therapies do better than FCR? I'm not going to talk at length about this trial because Ted Chanafel is going to present it later on, but I think it's important to point out that there is no significant difference until now in PFS for IR versus FCR in mutated CLL. And on the contrary, there is a significant prolonged PFS in IR versus FCR in IGHV unmutated cases. So until now, no benefit over FCR has been demonstrated for IGHV mutated fit patients with chemo-free regimen. But on the contrary, unmutated cases benefit from novel therapies in all the trials, including the elderly patients that you will hear about later on. So are there predictive genetic factors besides IGHV mutational status that we should consider? I think that you have heard yesterday from Costas and also from Richard this morning about the VH321 subset 2. It's approximately 3% of all CLL, and you have the information when you do the mutational status. And it's comprising unmutated but also mutated cases. But they are both highly unfavorable, whether the presence of IGHV mutations or not. So in our French philo group, we have decided that we will stratify these subset 2 cases with the unmutated IGHV cases. Notch mutation has to be kept in mind if you consider treatment including anti-CD20, because rituximab has been shown to fail to improve PFS with Notch1 variants in the CLL8 trial. But are there other factors? I think that most of the high-risk features until now are associated with either unmutated IGHV or TP53 alteration. It's probably too early and fish, and it's probably too early to consider right now anything else for stratification. There is a predictive factor of prolonged response, which is MRD. And we know that in most of the trial, MRD is a good surrogate for PFS. And I show you here the cohort of 540 patients in 3 French frontline trials with a median follow-up of 48.5 months. And you see here that MRD below the famous threshold of 10 to the 4 is highly predictive of prolonged PFS. And I agree with Andy that the MRD above 1% is just RD. Can we do better with immunochemotherapy than the regular FCR? Well, there has been previous attempts, like in our elderly fit trial, with 2 years rituximab maintenance after 4 FCR in elderly fit patients. And you see here that it has indeed prolonged the PFS, but it's not a license in that indication. And also replacing R by obinutuzumab in the green trial that was just published showed no unexpected safety signal and a low rate of progression and a high rate of MRD negativity with a blood MRD at 65% and marrow at 35%. So can we combine FC anti-CD20 with ibrutinib? Matt Davies recently published data on IFCR in young fit patients with 6 courses, including patients with TP53 alteration. And the response is deepening over time with a best bone marrow response, undetectable MRD at 83%. There is also the experience of the MD Anderson with FCGAI only 3 cycles, and in patients with TP53 alteration that were excluded. And these data are very, for me, promising, but the follow-up is still short. Later on, you are going to hear about that French trial that will be presented by Anne-Sophie Michalet. And we have done that pre-phase with obinutuzumab, and the patients received, most of the patients received the FCGI 4 courses. It was a fixed duration. TP53 alteration were excluded, and what's interesting, it's quite a large cohort of patients, and according to IGHV status, you see here that 12 months after discontinuation of treatment, the rate of MRD below 10 to the 4th is still very high. So what's the future? Probably combining novel agents, but we are already starting to see data on combining ibrutinib and venetoclax for high-risk patients that will be discussed later on. But the follow-up is still short, and notably the follow-up after discontinuation, and we have to see which patient benefit the most from that. But these results are very promising, and they are high MRD undetectable rates. So in conclusion, I think that there might be a relative consensus for 2019 that will probably change every year, but this consensus is, the problem for agreement is that the accessibility among the countries is not the same to the treatment. So I think that in conclusion, what I want to say is that we should consider both 17p deletion and TP53 mutation. IGHV mutational status is an important stratification factor if we consider using chemo. To date, FCR remains the standard of care for IGHV mutated young fit patients, and I think that the addition of ibrutinib is a promising option to increase the rate and depth of MRD. For IGHV unmutated, novel agents have been consistently shown to be superior to immunochemotherapy, so I think that we need an early access to these drugs. And a longer follow-up and new combination will certainly help determine the best regimen. I think that it's very important also that we consider discussing with the patients' associations about quality of life and how all these drugs that we consider as very good drugs are supported by the patients. So in frontline therapy for fit patients, I think that if there is TP53 alteration right now, the best option is ibrutinib because that's the access that probably all of us have. And in case of no TP53 alteration, for IGHV mutated patients, I would say FCR, and maybe for more elderly and a little bit less fit, BR. And for the unmutated, there are several options, but if nothing, for the countries where nothing is available, I don't think it's really a mistake until now to give FCR. Thank you.
thank you. That was excellent. Do we have time for questions? If anybody has any questions, they could come to the microphone. So at the back on the right.
Florence, excellent overview. Just a minor clarification regarding the Australian dose reduction study. Full dose versus a 40% dose reduction of FCR in patients over 65 has got an identical PFS outcome at 8 years. That was in ASH last year.
Sorry, Stuart.
Thank you. And
Matt Davids from Dana-Farber. Thanks, Florence. So in the US, we have venetoclax obinutuzumab also available now in the frontline setting. As you know, the data from CLL14 focused on patients with comorbidities. So how do you feel about extrapolating those data to younger, fit patients?
Yeah, I think that's one of the problems is that these data are, of course, for elderly patients. I think that we all want to have more data on fit patients. And I think that for younger patients, it's really important to use venetoclax with a fixed duration. Now, how is it going to compare with ibrutinib? And I think that probably, I would say that the most important answer is if you have your first course, what's going to happen after the second one? Because we are really talking long-term there. So is it better to have ibrutinib first and then when you relapse get venetoclax, or is it better to have a fixed duration, relapse later and then get ibrutinib? I don't have the answer.
Okay, if there's no more questions, then we'll thank you very much and we'll move on to the third talk.